But I literally walked in for your last class and then about face. And then somebody said, I thought you were teaching this class. I'm like, no, I'm not teaching it. No, MPH is good. It's an important class. Pay attention. You learn anything yet? All right. GI, one down, one more to go. Went all right?
Yeah.
My junior clin core group, sorry for blowing you guys up so much. Who else is in my clin core group? Where are you guys? Sorry. I get lonely at work, you guys can see me. Like, they're like, what are you doing, man? I'm like, it's a helicopter, my kids will really like it. Like, put it away, put it away. I feel like a tourist sometimes. Worked a couple shifts, Saturday, Sunday, and then yesterday, I just got lost in a vortex of like, I was trying to get myself in a Halloween, is that a word? Halloween mood. And I binge watched this Netflix series on a serial killer. It's disgusting. I feel like it really did something to me. Ed Gein. I feel like it might have like done something to me because I don't feel normal today. Bizarre. So if you haven't seen it, just stay away. Just stay away. Just stay away. I think my wife at one point was walking by like, what are you watching? I'm like, yeah, it's one of those. All right, I think we've got a bunch of slides. But this is, I think, the fun. I know I'm not looking at any slides, so I don't think I'm losing it here. But I think we're going to talk equilibrium today. So I did have a case over the weekend I thought was pretty relevant. So I had a 72-year-old guy that came in, ambulated in, from what I was told, but I hear water flowing. Is that in my head? Like someone's urinating. So 72-year-old brought in by his son. Chief complaint is he fell earlier this morning, or Sunday morning, and hit his head. So vitals were stable, unremarkable. I'm not going to make something up because I really don't remember them, but nothing crazy. And did a quick neuro exam, and it was normal. Past medical history, all the 72-year-old isms, right? So hypertension, hyperlipidemia, diabetes, on all his meds, no new changes, denies drugs, alcohol, or anything, no tobacco products. Physical exam looks normal, looks like a crotchety old 72-year-old man with a massive hematoma on his head. This is all I can see. And it's hemodynamically stable, like it's not really bleeding. So remember you guys are in the ER, so there's no wrong answers here. So what do you guys want to do? We're up front. What do you guys want to do? 72? My heart just melted a little bit. That's it, right there. Nothing else? But you're not even like, hey sir, nice to meet you. No, CT, right to the CT. All right. I can't even be mad at you. I thought this, like, in my head, I was like, this is going to take a minute. We'll eventually get there. But no, you guys crushed it. So I talked to him a little bit, and I was like, yeah, we should probably work you up. You know, did you syncopy? So that's the hematoma. The concern is the shadow under it. So he had a subdural bleed. And again, totally fine. I'll play that again. Maybe you guys didn't see it. But just play with the lights again. Or is that better? Works the same? Better. So I don't know if you can see my arrow, but clearly Ray Charles can see this, right? Not really my concern. Underneath this shadowing right here, so that's a subdural hematoma, which we talk about a little bit later. But so I mean, he had a brain bleed, which was fun for him. They didn't really want to do much for him. They wanted to watch him because he was stable. They're like, "How does he look?" And I'm like a 72-year-old. Yeah, we'll just keep an eye on him. I had to transfer him over to our neurosurge center because ours didn't want to take him. Like, there's nothing to do? No, you can't. You could evac that, I guess, if they wanted to, but really that hematoma is going to go away, and that subdural bleed, it wasn't huge. Like that, they'd probably leave alone on a 72-year-old. Y'all, they may drill. You guys are young and vibrant, you can handle it. 72-year-old, you might not like it. So. All right, what do you guys think about it? So equilibrium, we kind of talked about old man falling. What are some other things that come to mind when you think of the term equilibrium or disequilibrium, I guess? Infection, stroke, vestibular. You guys have had a lot of that stuff, right? Good. So we'll kind of speed through that as fast or slow as we need to. What else? Drugs, alcohol, vertigo. Excellent. Vertigo. What do you guys remember about vertigo? Anything? Has anybody had true vertigo symptoms, vertiginous symptoms? Can I tell you all my story of that? When I started teaching this class like 6 iterations ago, it feels like forever. And I was like, vertigo, whatever, right? And then like 2 graduations ago, out of nowhere, I just developed neuritis. Like vertigo was insane. I was sitting there talking to Dr. Love, and she was asking me questions, and all of a sudden I was like, whoa. And she's looking at my eyes, start doing some horizontal nystagmus. And she's like, what's wrong with you? And I'm like, I don't know, a lot. But and I like literally got up, and thank God there was an exit like right there, so I didn't make too much of an ass out of myself. But I got up, ran, and just laid out on the floor like belly flop style. I just had to sit there until the thing passed. It was awful. I think the funniest part of that at the time, the NCOs who were in the doorway, like I was like, no, get out of the way. and then I'm on the floor like flapping around like a fish, and they're like, you good, sir? You good? Yeah, you're good. Yeah. I was hurling, I was puking, it was nasty, it was violent. So when we get to vertigo, we'll talk, nystagmus versus horizontal versus vertical nystagmus, peripheral vertigo being intense, all that good stuff. I can attest to it. It sucked. And I just had to drive myself home for that, which is never a good idea. Like, I should have warned people, like, get off the road. It happened while I was driving, too. I just pull over, middle of the road, just stop. People would honk at me. So, they were all telling me I was number 1, though, which was super weird. Red face, veins popping out, telling me number 1. They weren't using this finger, though. Anyways. What else? Anything else with equilibrium? There's a lot of things. We don't have to spend too much time because there's a bunch of slides we're going to get through, but a lot of things can cause disequilibrium. Some of the things to think about too, what do you think? In the word syncope may or may not have came up, but really when I have a patient come in with equilibrium issues, whether it be syncope, pre-syncope, as I think of it in kind of 2 fashions, like is it a pump issue? Or is it a motherboard issue? Like, is it your head or is it your heart? So your heart will put you down, right? So your heart, if you're not getting oxygenated blood to your head, what's going to happen? You're going to go vertical. Like you're gonna go horizontal. Good catch. You're going to go horizontal fast. You're going to put yourself down, or your body is, just so it can get oxygenated blood to your organs. All right, ready, set, let's go. All right, so we kind of, again, TLOs, ELOs, I'm not going to go through these. Dizziness, some of this stuff up front is kind of boring statistics. I see it pretty regularly, at least once or twice a shift, but very common in the elderly, and then we'll talk about really what does the word dizziness mean, because it can mean different things to different people. When you hear the term dizziness, what do you think of? I see somebody doing this, like, woo, right? Like spinning. Am I spinning? Is the room spinning? Do I feel lightheaded? Then I have to sit down, right? It can be like, it can masquerade as some other things. And really, how do we snuff that out? How do we get that from our patient?
So let us know.
Yeah, we listen and we ask the right questions. OPQRST sample history, we're like, hey, can you explain it to me? I'm dizzy, like give me more. Is the room spinning? Or do you feel like you're falling, like you're on a roller coaster? Like, actually, it only happens when I stand up. And you're like, do you drink water? No. You take a lot of antihypertensives? Yep. You're probably getting orthostatic, right? So that's where you got to kind of play super sleuth to figure some of this stuff out. So, all right, some synonymous words: semantically, lightheadedness, faintness, spinning, giddiness. I can't stand that word. It's an ICD-10 code. You can use it if you want to. I don't know, when you think of giddiness, like what comes to mind? Yeah, I was like you guys have met my daughter, like not my daughter, but like someone her age being like, ooh, this is so good, right? All right, whatever. but it's often used interchangeably with some of the other words above. So some of the misleaders, right? Mental confusion, blurry double vision, headache, tingling, right? So we also got to think, and somebody may have mentioned it over here on this side, but with your disequilibrium or dizziness, those type of symptoms, what's also on our differential? Stroke, right? We can't just arbitrarily say like stroke's off. There's some things we can do to make ourselves feel more comfortable about it, like you guys clearly launched for a CT with non-con, right? So that's good. Before we got a blood sugar or anything else, you're like, get to the scan. Get to the scan. Yeah. All right. What do they call this? She's just totally definitions. There they are. There you go. So some definitions to know. So vertigo, a sense of rotational motion, usually indicative of a vestibular pathway issue. Disequilibrium, right? Unsteady, about to fall. Lightheadedness, about to faint. So these all kind of sound similar, but in your patient, you're not going to be like, give me more, like explain it. They're going to be like, well, actually, it's more of a disequilibrium than vertiginous symptoms. Like, they're not going to say that. You have to bring it out of them and then try to figure out which one it fits. And that may be harder than you think to do, and that's okay. I would say, like, if you're having trouble delineating whether it's vertiginous symptoms, disequilibrium, lightheadedness, pre-syncope, err on the side of kind of going big, especially in my opinion if you're in the ER, right? And you're like, well, I don't know, some of this may masquerade as a stroke. I'm going to work it up as a stroke regardless, instead of being like, you know what, that may be an otolith in your ear, like, and they're stroking out on you and drooling and their face is falling off, and you're like, yeah, it's BPPV, like, it's good, we're going to do this, I believe in it. Like, you're fired, right? So you're done. So, all right, syncope definition, what is it? Passing out. Anybody ever syncopize? Full spit. Only one of them? Only one. One of them. Like, one of you. Only one. Okay. Anybody see anybody pass out? Yeah, what does that look like? Yeah, it's kind of epic. I think it's great. It's great fun when you're expecting it. When you're not expecting it, it kind of catches you off guard. And always ask your patients too, like if they syncopize when they get blood drawn, or if you're giving them an IV, and if they say yes or they're not sure or they pause, just lay them flat. Don't worry. Nobody syncopizes when they're supine or laying down. So, did you guys switch seats? Did you switch seats? You did? Yeah. Good. My brain works. Anybody else switch seats? You used to be over there, right? Yeah, dude, you can't fool me, bro. Squirrel, right? Like, yeah. You guys can try that once a class. I'm going to find out who it is. Anybody else switch seats? No, everything else looks copacetic. All right. All right. So this is a popular thing to see. If you guys haven't seen syncopizing, you'll see it, right? And don't syncope can kind of like, again, we'll talk about it in a second. Especially your vasovagal syncope can almost manifest like seizure-like activity, right? So I used to have this, my sergeant major would always bring his driver around. This is my first unit. And they would always come down and, hey, doc, like, who's your most junior medic? I'd be like, I don't know, like, it's this guy, he's just got here. Like, we just pick anybody, right? Because we know where this was going. Like, make him give me an IV. And I'm like, you can do it. Like, you make him sergeant major, give yourself an IV. Like, let's teach that one, right? So he'd always offer up his driver, and every single time this dude syncopized. Every single time. Like, without fail. And he'd always think, like, he's like, I'm not going to pass out this time. And then he'd be like, oh, shit. He'd start yawning. I'm like, bro, fight it, fight it, fight it, fight it. And then he was like the Undertaker. He was like, ah. And he started shaking. I remember one time my medic was like, he's seizing. And I'm like, he's not seizing. He's being a jackass. Like, just lift his legs up. He'll come back. So it was always fun. So fun. I hated that they made him do it, though. He's like, you sure you want to do this? You could say no, and we can just not do it. He's like, no, they'll make fun of me. I'm like, they're going to make fun of you regardless. All right, 3 general types of syncope. We have neuromediated syncope, orthostatic, hypotension, and cardiac syncope. So I would kind of be familiar with those 3 if you're paying attention. Neuromediated syncope, so vasovagal is what we're talking about, the common faint provoked by fear, pain, anxiety, emotion, sight of blood, smells, odors. These are the folks that get diaphoretic pallor, nausea, and yawning. So not yawning. Yeah, this is gonna happen. So yawning is last there, but yawning is always the tip off for me. Why are these folks yawning? What's going on here?
Oxygen in the brain?
They're not getting oxygenated blood. Like, yeah, but why do I yawn? Let me think. I yawn a million times a day at iPad because I'm so bored, right? It's because your brain isn't getting oxygenated blood. So that for whatever reason, every time I've had a surprise syncope in clinic, they always start yawning. I'm like, put him down, put him down, put him down, put him down. He's going, he's going. What are you talking about? And he's done, right? Yeah, my last one was a CW5. It was epic. Oh, I'm really tired. And I'm like, oh, is this boring you? Night night, chief. All right. So rare and supine patients, so put them flat, and that'll help mitigate that. So, all right, Tacky becomes Brady. They appear ashen. Ashen gray. Depth of consciousness will vary, right? So they're not answering you. You can see there. You can see some clonic jerks. That's what I was saying about it mimicking like seizure activity. It is not a seizure. It is clearly a vasovagal syncope episode. So. What was I going to say with this guy? Oh, for whatever reason, my last one at Moreno Clinic, this dude, if I told you this, I apologize, but he begged me to take some little, I don't even know, hemangioma off his leg, and I'm like, nah, man, I'll send you to derm, they can do it. If this thing bleeds like stuck, like I'm going to get in trouble. All right, fine. He's like, I bet you won't do it. I'm like, say less. I'm like, yeah, we're going to do it now, so you want to sign this? Like, hey. And I did a punch biopsy on this guy, and he wanted to look at it. And the whole time he was watching me do it and show it, and then he just started doing the yawning and stretching, and I'm like, what are you doing, man? And then he just went out. And the tables we have at Moreno don't go in Tredellenberg, so you have to either lift their legs up or grab them by the chest and throw them on the ground gently. You know, But my nurse that was in there started freaking out because she's like, "We're gonna get some vitals on him." I'm like, "You're not gonna find any vitals on him." Like, he doesn't have a pulse. I'm like, "It'll come back. Chill out." Like, and she's got his manual blood pressure cuff on, and she's like, "He has no blood pressure." And I can be a little cynical, and I'm like, "He's probably dead." And she's like, "Should we call 911?" And I'm like, "No, we shouldn't. Let's wait longer." And she's like, "Does that mean yes?" And I'm like, "No, just lift his legs up." And she's like this? And I'm like, "Yeah, like that." And then he came back and was like, "Move up," and I'm like, "No." We had some fun at your expense, brother. But anyways, that's real easy, right? So if he's red, raise the head. If he's pale, raise the tail, right? Like I think the Disney movie taught me that. I can't remember which one, but all right. Moving on. Treatment, place. Yeah, I just said it. So there we go. Feel for improved pulse. Consciousness should return, and they're going to be fine, right? So we'll all get a good laugh out of it. They'll, eat some juice and crackers and feel a lot better. Make sure there's nothing else going on and send them on their way. So just tell them, make sure next time they announce that they do syncopize. So they won't do it, but you guys will get that. Right? So carotid sinus hypersensitivity, exactly what it says. Increased pressure on your carotid sinus baroreceptors. All right, usually after shaving, wearing a tight collar, or simply turning your head to one side. So this one should just make sense, right? So you're usually like occluding or something's going on with these carotid sinus baroreceptors. So usually men, usually older men, okay? Could cause sinus arrest, AV, I don't know why that's funny. Like, you're shaving one morning and all of a sudden that's it, you're done. You're like, or like you're shaving and someone's like, "Dad," you're like, "Get up." Wow. I read that sucks. If that happened to someone's family, I'm sorry, it's not funny. It's really insensitive to say that, but I just feel like that'd be a bad way to go. But, all right. Situational syncope, it is what it says it is. So you could be from coughing, so you could have like coughing related syncope, degglutination, swallowing, micturition, defecation, right? So again, not to make fun of this, but you get up at night to go use the bathroom, you're going number one, standing up there, next thing you know, boom, you're hitting the ground. Like, that's pretty pathognomonic that every time I get up at night to urinate, I pass out. So you're like, oh, that could be like a situational syncope secondary to micturition. So those ones are kind of easy to remember. Star this for me. You forever want to memorize this, and anytime you have a syncopal patient or disequilibrium, have your medics, or you just get orthostatic hypertension, orthostats on them, orthostatic vitals. So orthostatic hypertension definition is a reduction in systolic blood pressure of 20 or 10 diastolic, okay? And that's 3 minutes of sitting versus standing. So what is that actually telling me? Did I say it correct? Did I flip it backwards? No. So a drop in 20 systolic or 10 diastolic from sitting to standing. I don't care about your pulse. Yes, by the book, you can do it laying down, sitting and standing. I don't really give a crap about that. Sitting, 3 minutes, stand. What am I measuring, essentially? Volume, right? So volume, right? It's an easy way, especially if you have a patient that has nausea, vomiting, and diarrhea, and you have profuse volume loss, and you're worried about dehydration. You can do this, positive orthostats. I get a 20 change systolic or 10 diastolic. I know there's a fluid issue going on here. Old people, you think old people get dehydrated commonly?
Yes.
Yeah, so if I have disequilibrium, pre-syncope, syncope as their chief complaint, which I know they didn't put it there, it's a triage nurse, I just automatically order orthostatic vitals. And I want to know what those numbers are before I even ask them their name or how they're doing. So, polypharm, antihypertensive, antidepressants, so a lot of medications can cause this, right? Hypovolemia, okay, a lot of things can cause this. Treatment, reverse, if you know what it is, reverse it. If you know it's secondary to loss of fluid, let's put some fluid on them. If it's medication, let's change your medications, okay? Those type of things. So really underlying, the mainstay of this is treat the underlying issue if it's reversible. All right, cardiac sympathy. Syncope, I think I'm either stroking out. I'm mixing words together. You guys are just letting it slide. Can somebody please ask me to smile, hold my hands up? All right. I think I'm trying to go too fast because you guys have had a long day. So, all right, cardiac syncope is exactly what it says it is. It's related to your heart. So usually caused by an arrhythmia or structural heart disease. All right, big thing about cardiac syncope is, I think I told you guys earlier, this one will put you down fast. So there's no prodrome. I told you about your vasovagal guy that gets tired and starts yawning, right? Just like you were. Thought you were going to pass out for a second. Cardiac, you're just walking along. Maybe you go into like WPW. What happens? Boom, you go down. You have like a drop attack. It's pretty quick. All right, what do we do to... You guys are in cards right now? Or EKG cards, something like that? I've only been here 3 years. I don't know what the classes are. So. Block 2? Okay. So what do we do with this is we try to figure out the underlying dysrhythmia and then fix it if we can, right? So maybe they need an EP study, maybe they need medication. But in order to figure out what we need to do to fix it, we got to figure out what it is. So EKG would be a first good place to start. So. Differential diagnosis, hyperventilation syndrome, seizures, we'll talk about a little bit later, hypoglycemia, hemorrhage, aka stroke, general anxiety disorder. So consider your psych differentials. So MDD, panic disorder, somatization disorder. What's somatization disorder? What do you say? It's in their head. Is it make-believe?
Neuro. You have real symptoms for neuro.
It's real to them. It's real to them, right? So it's real to them. Or hysterical fainting. So, all right, differentials. This kind of helps you a little bit. So vasovagal, usually related to postural changes, emotional stress, pain, restraining. And then cardiovascular, you can see there, usually patient in a recumbent position. So just some things that are like-minded. This other one, I think this does it a little bit better. So upright sitting positions, yes, orthostatic, hypertension, laying position, cardiac event or seizure, exercise induced suggests cardiovascular etiology as well. So just some things to consider. It's not all encompassing, but again, if I give you somebody, a patient that having drop attacks, sudden, no prodrome, I want you guys to think cardiac, but this is a neuro class, so I probably won't give you cardiac symptoms. All right, EKG we talked about, right? So you can do autonomic testing or tilt testing as well, which I don't do this, but you can refer them out to neuro who can do this or cardiac who can do tilt testing as well. So this involves moving them in different positions, okay? Passive tilting of angles between 60 and 80 degrees, 30, 60 minutes, okay? You can also, you can use some medication infusions as well, so stressing the heart out. I've never ordered a tilt or autonomic testing on a patient. So. All right, vertigo, defined as rotational motion or hallucination of movement. So patient versus environment. Do you feel like you're spinning as the room's spinning around you, or do you feel like you're just getting lightheaded and you sit down? So impulsion or oscillopsia. What is oscillopsia? I'm not making that word up. It's actually there. You're like an oscillating fan. So back and forth, right? So the move or the sensation like you're moving back and forth and being thrown to and from. So it's kind of would be uncomfortable. So does anybody look at that little like swirly thing and see anything, or does that do anything for you? No, nothing. No like 3D effect. Like, oh, it's no, nothing. All right. Yeah, me neither. Supposedly some people say like it looks like it's moving. I don't see it. Does it? Do you? Nice. 1%. All right, a little bit about vertigo. We talked about it. We said this before. 3 things we need for just ambulating and our balance, right? So one of them we talked about vestibular cochlear system. So we're now into the vestibules here. So the semicircular canals. You guys remember this from anatomy, right? Those little kind of ovoid-shaped canals. And what's inside those? Anybody remember?
These crystal things.
These crystal things. Is it like gelatinous or is it? It's like endolint, right? Yeah. So little hairs, right? They keep our balance. Just in mind, so I guess. What's that?
Otoliths?
Otoliths. So hopefully you don't have otoliths or calcium stones, but you could. We'll see what happens here. So shake your head around and see if you decide to go on the iron rattler real quick. But. All right, so our exam orthostatics, look for nystagmus, which is that beating of the eyes we talked about. Check for bruits. We're going to do our cerebellar signs, Romberg, gait, finger to nose, heel to shin. Weber and Rene, y'all remember that? You and I have some Weber and Rene history, so don't be saying you don't remember it. Oh, I remember. Yeah. It's a real thing. How many times have I done Weber and Rene on a patient?
So many.
How many people say 1? People say 0. It's tough to answer. Like when I was here, I thought it was the bee's knees. I do it on everybody. You'd be walking down the hallway and be like, "Yo, can I Weber and Rene just real quick?" In clinic, nuts. Yeah. So sorry. Should I? Probably. All right, hearing, some plug on Weber and Rene. So again, just refresh your memory on those. We're not going to spend too much time on them, but what is so 1, how do you do Weber, how do you do Rene, and 2, what is it concerning, what is a normal finding? So go back and retrieve that and take a look at it. You're like, right now, I'm not thinking about neuro, that's fine. When we do the review, I think there's a question or 2 on it. I can't remember. I got to pull the test because it's still in the little word bank here, but there's a bunch of questions on there, so you could probably get one of those. All right, nystagmus, involuntary oscillation of the eyes, characterized by position of gaze, amplitude, and direction. You guys, I think, have had this before, so if I'm going too fast, tell me to slow down. But you can get pendular nystagmus, back and forth. You can get jerking pendulum nystagmus, which is this fast and slow phase, right? And they call this saccades and pursuits. Saccades is when it goes fast, and then it slowly comes back, and it shoots fast, and you're looking at the eye. How do I find this in a patient? Like, how do I find their eye doing this crazy movement? You do your H's, right? Follow my finger, follow my otoscope. With your eyes, don't move your head. And what's the first thing you do? Move your head. All right. Now do it the same, but keep your head straight. You're like, oh, okay. But you got to look for it, okay? You got to look for it. You got to do your extraocular movements. So, bashed Weber and Rene. Sorry, Dr. Weber, Dr. Rene. How many times do I do extraocular movements on patients in physical exam? Pretty much all the time. Pretty much every patient I'm concerned about with any type of neurological complaint, headache, or possibly stroke. Every single patient. Got to be fair both ways, right? Got to be fair. All right, finger to nose. You guys know this, right? We're isolating cerebellar portion. What other tests can we do to isolate cerebellar portion of the brain? Finger to nose. What are some other ones? Feel the shin, dyskinesia. What else? Yeah, walking. Exactly. Yep. Yates. Good. Good. You guys are crushing it. All right, Romberg. What's the Romberg test? Yep. Hold your arms up, keep them out there, close your eyes, don't let your arms fall down, right? right? And yes, you can try to move their arms down and they should come back into position. So what's a positive romber? If I have a patient that's like this, they're like, hold your arms up. First of all, not funny, but like, I've had stroke patients that I'm like, all right, sir, ma'am, I want you, I don't know who it was, but I want you to hold your arms straight out in front of you like you're holding a pizza, right? And don't let them fall down. And they're like this. And I'm like, oh, what's up with that arm? Like, it just doesn't want to work. It's like, no, they're having an MCA, major stroke on the right side of their brain. So some of them can be that positive, or sometimes you may just see a subtle difference, right? So this one, obviously, you're going to go get a CT non-con. This one, obviously, you're going to go get a CT non-con. So I've got them, both of them. Get them out of here. Make sure they're stable first. Make sure they're stable first. All right, nystagmus, a little bit more of that. I don't know what that picture's trying to show you. You can just delete it. So, big question about vertigo is central or peripheral. Do y'all remember central versus peripheral vertigo? Which one's okay, or which one's better? Peripheral vertigo is worse for the patient, but makes me feel better because it's less serious. Central vertigo is kind of scary, right? It's kind of scary. I would like you guys to star this, right? So just kind of, as you're going through studying this, eventually when we get to it, you know, the last week of the test before we have it, just understanding the difference of the two. So I would say, and you're like, oh, there's a lot of words on there. What do you really want me to know? So with peripheral vertigo, it's usually always horizontal nystagmus, never pure vertical. And then with your central vertigo, yes, it can be both, but in my case, I'm going to give you guys vertical nystagmus. So if I give you a patient with vertical nystagmus, you need to think central vertigo. I will not trick you. If I give you intense, short-lived episodes of dizziness, paroxysmal symptoms that has horizontal nystagmus, you're going to think peripheral vertigo. Hints exam. Have we talked about hints? I thought I was going to delay this too. This is easy though. Head impulse, nystagmus, or test askew, which is an acronym HINTS, and I think I hit this at the end, it's stroke.
You don't have this slide.
I did, yeah. So I'm just throwing things in there at random. But never mind, if you don't have it, it's not real. So HINTS exam is something, I will talk about it real quick. I don't think maybe there's not a test question on it, or maybe I'll write one, or I don't know what I'm going to do with it, but it's pretty simple. So really, we're trying to find a way to snuff out the nystagmus, essentially. So easy acronym, head impulse, obviously HI, nystagmus, and then test askew. But your head impulse test, so you guys can see at the bottom there, so you have your patient look straight at you, so just look at my nose. I've seen some crazy clinicians do this where they're like ripping heads back and forth, but I just like take their head and move it, and I'm like, keep your eyes straight. So if you're a normal physical exam and you're supposed to be looking straight at my nose and I'm moving your head, what should your eyes do? Stay straight. If I'm doing this and my eyes start going over here, that could be a concerning finding, right? So I'm like, hey, and then you're like, what? Maybe you didn't understand what I said. Hey, I want you to look right in between my eyes. I'm going to move your head side to side. Do not stop looking here. And you're like, oh, okay, yeah. And you're like, oh, something doesn't make sense here. Nystagmus, same thing. When I'm moving their head, I could be looking for a correctional nystagmus. So I could move their head and they could have movement but correct back, and you could see some beats backwards, right? And then test askew is kind of cover on cover, you guys can see there. So again, looking for nystagmus or any deviation of the eye. But we'll talk more about that later. I have no idea why I put this on the slide deck today. But it was exciting. I was passionate about it, at least. So, all right, peripheral disorders in general, outside of the brain itself. So remember we said peripheral, worse symptoms, less scary, but this sucks for your patient. So outside of the brain, sudden onset, lasting a few days, intense symptoms, brief periods, significant distress, no neurological findings on exam. So no neurological findings on exam, their exam's pretty benign, it's pretty normal, but do you think these folks are going to come see you if they're having intense episodes of vertiginous symptoms? Like I wake up in the morning to turn over to shut my alarm clock off and I just start hurling and I'm on like the Iron Rattler roller coaster and it won't shut off. Like, I'm going to come see you as my PA, right? Like, can you fix this? And you're going to be like, actually, I can. So some different types. We'll go over these individually. Don't let the, are yours folded like that?
No.
Okay. I think the last test I had where there was a question on each of these, just ignore that for now. I'll let you guys know. Or maybe we'll just keep the same test. I don't know. We'll see what happens. Try to get fired. They don't like when I do that. Are you recording me again? Are you recording me?
I cannot be.
No, it's alright. This is Colonel Gutierrez again up here. Alright, vestibular neuronitis. So this is what I had. So paroxysmal. What does paroxysmal mean? So up and down. It's really fast onset, abrupt onset, and it's intense. That's all I want you guys to know. Usually a single attack. In pure vestibular neuronitis, auditory function is preserved. Okay, so just that's underlined for a reason. Circle that. Do whatever you got to do. When you lose hearing, it's called labyrinthitis. So really, the only distinguisher between neuronitis and labyrinthitis is the hearing portion. So that'll be kind of important to remember moving forward. So, all right, in the acute phase, you'll see a nystagmus. What type of nystagmus do you think I'm going to see? Horizontal. This is a peripheral vertigo, right? So horizontal nystagmus. Most patients recover spontaneously. Steroids can help in the first 3 days. Vestibular suppressants. Usually, if you catch it early enough, your benzos, antihistamines, so meclizine, diazepam, those are going to be good choices. After that, they're not really going to do much. Things that get your patients addicted to Valium or whatever, which is a problem. Keep you in business, but it's a problem. So, you can do vestibular therapy. PTO, or really physical therapy, will focus on core stability and any prior physical therapy techs in here? Or PTs, period? Nobody? Vestibular therapy? We're going to cover like rotational movement and space, body awareness and stuff like that. So it says there no proven benefit to antivirals. I think I jumped over it, but this is thought to be related to a viral illness. So viruses, right? Body attacks a virus, causes all sorts of cytokines, leukotrienes, substance P, all that stuff that you guys thought you're never going to have to remember, right? All your body attacks it. That swelling could create this secondarily to fighting off the virus. So, but antivirals aren't going to do squat. Labyrinthitis, same thing, but now you get hearing loss. Okay? Continuous severe vertigo, days to weeks, and hearing loss. So if you think neuronitis is lasting long, just think labyrinthitis. Yep, if they got signs of infection, you might need to treat it with antibiotics. If they got fever, what are some other signs of infection?
Purulent discharge.
Purulent discharge? Sure. They got purulence draining from their ear. Redness. You guys remember rubor, calor, trulor, domor? Did you guys learn about those? Yeah. Bust you out some Latin there, right? It's pretty good stuff. So, tachycardia, so elevated heart rate, right? So heart rate alone with fever, those are like 2 or 4 Sears criteria. Plus, if you get a lab, you can get leukocytosis and just mail it in. So, all right, same thing. Vestibular suppressants in the acute phase. I'm going to go through these and we'll take a break. Labyrinthine concussion, right? So this is secondary to, this is secondary to some sort of trauma. So you can see there it's the most common cause of vertigo following a head concussion. Usually symptoms get better after a couple days, associated with a basal skull fracture. You get severe vertigo, episodes days to weeks, deafness in an ear. So what sort of things do you think will cause this? Yeah, get punched in the head, hit in the head, slapped in the head, right? So you get like barotrauma. You can create some sort of like combatives patients. I say they're patients, but your folks that are going to come see you fighting in the barracks, like learned some BJJ stuff and wanted to try it on their buddy. And they charged at him and smacked him in the head, knocked him out. Now they got a labyrinthine concussion. So. All right, treatment, supportive care, vestibular suppressants. Again, you can start to see a pattern here with our peripheral vertigo. Diazepam, meclizine, and then vestibular therapy is persistent as well. So, many years have you had this? You're the only one answering. No, you. Don't look away. All right, there's a triad here: deafness, paroxysmal vertigo, and tinnitus. Right, so that low frequency tinnitus. What's causing this? Do you guys remember? It says it right there. It's a dumb question. So, usually secondary to increased fluid in the ear. So if it's increased fluid, what are we going to do to treat this patient?
Dry 'em up.
Dry them up. Good, perfect. Before we get to the treatment, if I find somebody that I think they have veneers, send them for an audiogram. You guys, is that something HENT plug for you guys? Yeah, always. Like, you'll get the diagnosis and be like, sweet, a triad. Like, I think it's veneers. Make sure you get them sent out for a baseline audiogram. Okay. We may need to track that because this can get worse or it can get better. So, like a lot of things. Avoiding salt. Why salt?
Causes water retention.
Pulls water. Excellent. You could use a diuretic if you needed to. Maxide is one. Don't memorize it. Your meclizine, scopolamine, and diazepam has a play in it. Hearing aids if you need them. Injection of gentamicin into the middle ear. No kidding. What did you guys learn about gentamicin? It's autotoxic. So why would I inject gentamicin that's autotoxic into the middle ear? What you say? Because it's crazy? Yeah, you want to act up? I'll show you how to act up. I'll put you guys down, right? So you're temporarily like taking that middle ear and putting it down, man. So their symptoms get better, remarkably, but they may have some permanent hearing loss. So it's crazy. Yeah. You guys can Google it. It's nuts. Yeah. Have I done a gentamicin injection in someone's middle ear?
No.
Will I do a gentamicin injection? No, I will never. Way outside my credentialing package. I actually don't know. I was reading the other day to see if HENT still does it. I think they're getting away from it. But anyways, it's autotoxic. You put, your ears acting up. You just inject enough. You're like, oh, gentamicin. I could do like radiator coolant too. You might be able to do that. I wouldn't recommend it though. So, all right. We're actually taking a negative side effect of the medication and using it to, I don't know, our advantage, I guess, depending on how bad the patient's symptoms are. So, all right, perilymphatic fistula. This is a connection, right? So fistula just means a connection where it shouldn't be. So you got inner ear into the tympanic cavity. This can be caused by physical injury, extreme barotrauma, vigorous valsalva maneuver. So when you guys are downstairs and you guys are playing, doing physical exams, and you're like, valsalva for me, be gentle on yourself. You don't want to create a fistula, that would be bad. So, can also be after middle ear surgery. So, conservative management is the way we're going to treat it. Bed rest, head elevation, and avoidance of straining. Right. So, hopefully that fistula closes off, and if it doesn't, we're going to send them to the right person. They might need to get it fixed. So, ENT. BPPV. You guys feel pretty good with this one? Does everybody remember it? So, benign paroxysmal positional vertigo. This is your patient that wakes up, turns their head, and they're on a roller coaster, right? They've got the otolith in their ear that's going through that semicircular canal. So they get brief sudden episodes of severe vertigo, typically with nausea, vomiting, and it's usually with secondary to head change and position or posture. So it's an otolith or calcium carbonate crystal in the semicircular canal. All right, you get no hearing loss. It says positional nystagmus is always present. What type of nystagmus am I going to see with these folks? Positional, you're not wrong. Horizontal or vertical? Who says horizontal? Who says vertical? Who says they don't care? Thank you for being honest. So it's going to be horizontal. They're going to have horizontal vertigo. Remember, we said vertical vertigo is going to be concerning for what? A brain issue, like stroke, tumor, that type of stuff. That's scary stuff. So these folks, right? So bedside, we can do a Hall pike maneuver. So you can slowly move them down at the end of a bed, move their head, and see if you can actually exhibit some of those symptoms, right? You can do Epley's repositioning maneuver. So you're going to try to move that otolith back to the base where it needs to be. It kind of feels awkward when you do it for the first time. I remember I was super stoked when I saw BPPV, and I'm like, I know what this is. I can fix this. But usually the biggest problem you have is not really understanding how gelatinous that fluid is, so it doesn't happen fast. It's like a slow moving. So like I'm like, oh nice, I got you, right? And they're like, what the hell are you? Like, oh, you made it 10 times worse. And I'm like, let's do it again, but with Valium and meclizine. And they're like, oh, this is way better, right? And then you can teach your patient to kind of do it themselves when they wake up in the morning, hang their head off their bed and slowly kind of move their own head so they can reposition that. That's kind of advanced level stuff. But what else do we have here? Hold on, how much more do I have? That's a lot. God dang.
We're halfway.
We're halfway. We'll take a break. Let's take a break. I can't do this. I was like, we're gonna keep going. We'll take a break. A good serial killer show is Dexter. Anybody watch Dexter? I'll plug that one. The new Dexter one's pretty good too. So I'm not like a weird serial killer fetish person, but just we'll move on from there. So all right, we're talking about peripheral vertigo. Peripheral vertigo. I don't say good or bad, but is it super scary?
No.
No, right?
Ears are broken.
What's that?
I said ears are broken.
Ears are broken. Something's broken on the inside, right? So brain is okay, right? We haven't got to this crazy brain stuff. I should have gone like 3 or 4 more slides because then we end peripheral vertigo, but I didn't do that. I just decided I'm just going to stop right now. So we were talking about BPPV, and acoustic neuroma is something else that can cause peripheral vertigo. What does that name sound like to you guys?
Tumor.
Neuroma?
Cancer?
Yeah, I mean, it sounds like a malignancy. It is. It's a benign tumor from cranial nerve 8, right? So in the internal auditory canal. So it's also called an acoustic schwannoma. You get insidious onset of hearing loss, tinnitus, headache, vertigo, facial weakness. How do you think we're going to find this? Soft tissue, benign mass in the inner ear. I'm not going to see it, right? I can't see your cranial nerve. So neuroimaging. Most likely you're going to probably get an MRI for this one. I know you're like, CT? I feel like he wants us to say that. I would probably get that beforehand and maybe I'd see something, but to define it better, I'd want to get an MRI. So, all right, pathophys, you know, if it's called an acoustic schwannoma or neuroma, it's probably going to be from our Schwann cells. So. Don't remember statistics, but 8% of intracranial tumors in adults and 80% of cerebellopontine anal tumors. So you will see these out there, and just keep it on your differential, especially if you're thinking peripheral vertigo. So, okay. Could be asymptomatic, right, all the way to hearing loss, vestibular symptoms, facial paresthesia, and pain. I would say if they're asymptomatic, you probably don't have a reason to do an MRI unless you're really bored and just decide you want to spend thousands of dollars on a study just to make sure he or she doesn't have this. But they're going to come into you with symptoms of peripheral vertigo. Just keep this on your differentials. MRI with con, can you guys see that? Positive arrow sign. Yeah, so obviously that white circular ovoid area, that's your acoustic neuroma there. So, okay. All right, MRI with con is the best study, and this is going to require surgery. Do not remember this. It doesn't matter if you remember the type of surgery. You're just going to remember that you either. Who do you think you're going to send this to neurosurgery or ENT? They're going to argue. Like, they're going to argue over who's going to do it. But I would call neurosurgery, right? It's within the cranial nerve, CNS. And depending on the day they're having, they'll be like, you know what? Call the ENT, see what they're up to. And then you might have to get them together to have a cup of coffee and figure it out. So, all right, the last peripheral disorder we'll talk about is your vestibular migraine. If anybody has migraines in here, they know they're pretty miserable. And if you have migraines and one of the symptoms you have is vertigo, that's miserable on top of miserable, okay? So you can get episodic vertigo. It can be related to your headache. It could be minutes to hours. There could be a positional component, and then you can get disequilibrium lasting for days to weeks, right? So treatment, we'll talk about headaches and migraines specifically. Dietary changes if you know there's a trigger, migraine prophylaxis, and some antiemetics if you're nauseous. Do you guys have you had migraine medications and all that yet?
This block we're in right now.
Oh, you are? Good. Oh, that's very apropos. Do you remember any of them? Nice, awesome, great. So really we'll simplify it. So we talk about headaches, primary headaches and secondary headaches. Your primary headaches, the most common type, I'm totally off script here again, are going to be your tension and migraines. And usually analgesics will work good for those. So your first line would be like grab a Tylenol like under Motrin, right? Maybe some Zofran if you're nauseous, and I'm going to watch it and see how you do. Or, what else can I do? I can see through your head until it stops. I'm just kidding, that's not funny. You could do, so I have a lot of times, and again, I'll save this for headaches, but if I'm doing baseline labs, Obviously, sometimes, you know, my females will come in with headaches, want to make sure they're not pregnant, so I'll get an ACG, CBC, CMP, just to get some baseline labs, kind of make myself feel better that they don't have any type of infectious pathology going on. If I had to get you a Lyme, I'll probably give you some Toradol, Reglan, some Benadryl, put you to sleep, make you feel a little bit better. So there's plenty of ways you can treat headaches. We'll get to that a little bit later. All right, that is the peripheral disorders. Now we talk central. So we said central is ungood, right? So this is kind of that scary stuff. This is due to disease pathology originating within the CNS, okay? Lesions within the brain itself, either the cerebellum or the pons. They can get ataxia, which is what?
Gait disturbances.
You say sleep disturbances?
Gait
Disturbances, good. Yeah, absolutely. Gait disturbances, vertigo, and often with nystagmus. For our all purposes here, we're going to say what type of nystagmus with central? Vertical, right? I'm not going to trick you guys. So, symptom presents slower over several months. Why do we think these are slower, potentially?
Because they're central.
Right, so if I have a mass growing inside my head, it may be not that rapidly expanding, right? Slower, and it could be less drastic of symptoms. That's why I said earlier, your peripheral vertiginous patients are probably going to come kick your door down before your central vertigo. We need to consider these, absolutely. But if I wake up in the morning tomorrow and I roll over and I start projectile vomiting and I can't walk, right? I'm going to go get help pretty quickly. If I have a tumor that's growing in my head, I'm walking around, get a little bit dizzy, and I'm like, whoa, all right, that's gone, I feel better. Maybe I'm going to put it off, right? I'm not going to go see doc right away. I'm going to wait till it starts getting more severe, and then I'm going to come see you. And they say, hey, Chris, how long have you been having these symptoms for? And I'm like, about 6 months. And you're like, where the hell have you been? Like, oh, I just got busy, right? And they're like, no, this could be getting worse. This could be scary. So. All right, could also have other focal neurological signs, right? So what does that mean? Cranial nerve, we're going to do our cranial nerves. Maybe they have a upper lower motor neuron issue, or maybe they have some sort of muscle wasting or something. That's why we get through our whole neuro exam. Sharp, dull, all that good stuff. So you could see this with stroke, hemorrhagic or ischemic stroke. You could also see it, we talked a little bit about cerebellum, vestibular nuclei, connections in the brainstem. So if I had a mass or something growing in my cerebellum, I feel like I asked this already, what are some things I could do bedside to assess your cerebellar function? There's a reason I say these things more than once. Absolutely, walk your patient, dysdiadochokinesia, finger to nose, heel to shin. That's good. You guys good? Good. And again, I'm trying to make this stuff relatable. Like, why do we do all that stuff downstairs? It sounds mundane, and you're doing it to a healthy person, and you're like, ugh, I'm never going to do this, right? Because I'm just going to get a CT with non-con, and it's going to solve all my problems. Not necessarily. I'll joke about it as much as the next person. Like, I do order a lot of CTs, like 100%. I absolutely love them. It's great. And sometimes I'm scared not to order them, and that's something I'm working through. But I also do the physical exam stuff, and I have to have a reason why I'm doing it. So, all right, disequilibrium could be based on the location, right? And again, we talked about this that first class when I said find the lesion. What is the patient presenting with, right? And try to reverse map that to the certain part of the brain. Okay, I know that's easier said than done, but some of the things here, right? Cerebellum in coordination, basal ganglia, impaired postural reflexes. So this is why we do our physical exam. Sensory tract or receptors, impaired proprioception, right? So those type of things, okay? All right. It could be a vascular issue, an infarct, a atriovenous malformation, arteriovenous malformation, excuse me. Yeah, another TIA up here. Tumor, or you could have some chronic disease pathologies, MS, which we talked about last block. Alcohol, like severe alcohol, Wernicke's encephalopathy, that type of drinking can cause this. Hypothyroidism and congenital, right? So hypothyroidism one is we typically don't even think about, but easy, just if you're pulling labs, get a TSH for this patient. And then congenital, right? So talk to them about family, birth history, et cetera, if that's pertinent. So, all right, some common causes. Vertebrobasilar insufficiency or ischemia. So the first two are just strokes. Strokes and tumors, essentially. Strokes, tumors, and MS. MS we already talked about, so really just narrow it down to strokes and tumors. Do those sound scarier? Is having a stroke or a tumor in your head sound scarier than a calcium carbonate crystal floating around in your... I don't want either, don't get me wrong. Like, I'm not about either one of them, but I'd rather have a crystal where you can spin my head in circles and get it back than have a massive tumor where you have to cut me open or something. All right, again, consider any patient, so your ischemia or insufficiency, so this is ischemic strokes are 80% of your strokes. This is a lot more common than your hemorrhagic, we'll talk about later. But consider this with new onset and vertigo without an obvious cause. Usually diplopia, right, dysarthria, they can't see, they can't talk, they can't walk, and they've got some numbness, right? So those are all stroke signs that we'll talk about in a couple blocks. Physical exam, look for brainstem dysfunction. What is the brainstem responsible for? Vitals, breathing, heart rate, right? So that may be all we get if the patient's in a motor vehicle accident. Man, we just got back, didn't we? We just got back from a break. Do y'all need another break? No. Yeah?
It's a test day.
All right. Yeah, another 4 day? Well, if we go to 7 o'clock tonight, you guys can have. All right. Looking for, it says multi-directional, but look for the vertical nystagmus. You can underline that. So again, for our class, vertical nystagmus, I want you guys to think central vertigo issues, okay? MRI, right, is going to show ischemic infarction, and then ultrasound could show you some vascular disease. So a lot of times with these folks, you guys notice that CT non-con's not up there. What does that mean? It just means I didn't put it up there. You think I'm going to get a CT scan non-con first?
Yes.
Yeah. And when we get to stroke, we'll talk about that. A lot of times, I may see a patient that has stroke-like symptoms, get a CT non-con, ischemic signs or ischemic findings, radiological findings show up a little bit later. So I may get a CT non-con and just rule out that it's not a massive hemorrhage. And that's good, because now I'm like, there's no active bleeding, they may be a candidate for TPA or your thrombolytics. But I still might not find anything. Maybe I do, maybe I don't give them thrombolytics. They're in or outside of the window, and I might admit them just for an MRI later on. That's fine, because your MRI is going to be more sensitive and specific, but I can't send them there right away, right? And I still need to get that CT non-con first to rule out a bleed. Does that make sense? All right. I'll put it back up there so we can talk about it again. But, all right. Yes. Cerebral infarction, yeah, this is all good. So sudden onset, loss of balance, difficulty maintaining posture, walking, right? So this should all kind of be concerning if your patient has some of these issues. And if they have postural issues or issues ambulating, for this, I want you guys to think cerebellar portion. Think we might have, maybe I hallucinated, but usually that first stop of your anatomy off that vascular to the cerebellar is the posterior inferior cerebellar artery. Did we talk about that? So that first bifurcation is usually where you're going to see a lot of your cerebellar strokes, just based off anatomy alone. So again, for our class and purpose here, if they have impaired movement, finger to nose, heel to shin, hands moving back and forth, and we don't want to think it's a cerebellar issue. Okay. All right. Management, we're going to work them out. We're essentially going to try to rule out any other cause that could be masquerading as a stroke. So anemia, pregnancy, glucose, yeah, that's fine. MRI, we may need to admit him for this to look for a microinfarct, hemorrhage, tumor, any type of soft tissue pathology, okay? If it's Wernicke's, so Wernicke's encephalopathy is that chronic alcoholism, thiamine replacement, banana bag, that's not a bad idea. MS flare, prednisone burst, see our last block we talked about, and then avoid offending agents for sure. So if someone makes it worse, you want to avoid it. So MS, you guys remember MS? Just had a couple questions on MS. I think I asked like 3 of the same questions, just a different way. It's like steroids, and steroids. Good. All right, definition stuff. So kind of dovetailing into seizures now. So definition of loss of consciousness. when the function of both cerebral hemispheres of the brainstem, RAS is compromised. So not the RAS you guys are learning about blood pressure medications. This is the reticular activating system. What's the other one? Something or other. Renin-angiotensin something. Yeah, you guys got it. So we're talking about the reticular activation system is compromised. So episodic dysfunction produces transient and often recurrent loss of consciousness. So two main types. We just talked about syncope, and now we're going to talk about seizures, right? So in your own words, what do you guys think a seizure is?
Spasmodic moving, foaming at the mouth.
Random brain firing.
Random brain firing?
Yeah.
I like it. I'll buy it. So can it be like, I don't know, partial? Like, can I have a partial random brain firing on a part of my brain, just creating one effect? Like, the part that controls this arm is just firing?
Yes.
Could it be generalized, where it's my entire brain, both hemispheres?
Yes.
What does that look like?
Random.
Whole thing? So tonic-clonic activity, fully stiffening or active? Okay, got it. Yeah, I like it. So we all understand that, generally speaking, the brain works on electrical impulses, right? It should be a linear process. It should be neuron to neuron. Like, my brain should tell my arm to do this and move, right? If you send too many signals too fast and you overload the circuit, what happens? It goes haywire, man. It goes haywire, right? So we're talking about the different types of seizure. It's an oversimplification, but sometimes you just got to make it simple, I think. So, who can have a seizure?
Anybody?
Anybody. And what can make us more prone to these? Sickness, is that what you said? Oh, epilepsy is a seizure disorder itself. Medication can decrease seizure threshold. Geriatric patients, hitting your head, bleeding in your head, right? So we talk about strokes. Stroke patients are more prone to have seizures. Why? I don't know. If you pop a vessel and it's bleeding on brain tissue, is that going to be concerning for seizure activity? Yeah, so that's why all you prior combat medics, are you guys taught to give like 2 grams of Keppra to some of your intracranial pathology? Yeah, why do we do that? They're not seizing yet. Prophylaxis, right? Because we're going to seize eventually, or we're trying to prevent them from seizing. Cool. All right. Common problem you guys see there. It can be worrisome. Anybody seen a seizure in person? Yeah. I mean, has anybody not? Let me ask a better question. Anybody's not? Okay. Yeah. The first time you see them, they can be violent, right? They can be violent. And what's the first thing that happens when, I don't know, I can't say this with a 100% certainty, but first thing I think anytime that I've been with a patient that has a seizure, they're always looking for the medical folks to do something, right? Like, oh my God, they're having a seizure, do something. What can I do for a patient that's having a seizure? Protect them from themselves, really, and kind of watch the clock. And we'll talk about that in a second, because I don't want them to go into something called status epilepticus. But in reality, there's not a whole lot I can do. Like, should I try to start a line on a patient that's actively seizing? You have to be pretty damn good. Could I walk around with benzos and give him an IM injection of a benzodiazepine? It's not a bad idea. I don't know that happened. Yeah, you get some Versed, yeah. But we'll talk about when are these concerning, when are they not concerning. But I'll tell you, like, anytime, I remember being in Jordan and they brought a Jordanian. He either hit his head and seized or seized and hit his head. I was never able to put it together, but he came in with a huge laceration in his head and he was actively seizing, and his buddies brought him in and like put him down on the bed, and I'm like, okay, like somebody watched the clock, like, and they were like, aren't you gonna do anything? Like, you're from the US, like your medicine's better than ours. And I'm like, nah man, like we're gonna just watch this and see what happens. And I just told one of my medics, was like, I'm gonna start a line. I'm like, go for it. I wanna see it. We won't stand still. And I'm like, yeah, damn it, that's weird, right? But in real talk, I was like, hey, drop some Ativan in the meeting to do an IM shot. Otherwise, just protect himself. Left lateral recumbent position. You don't want them to bite their tongue. Should I put my hand in their mouth? No. Where the hell does that one come from? Like, I swear I heard you should put leather in their mouth. And I'm like, maybe like Davy Crockett style. Like, I hear if you give them a swig of moonshine, it gets rid of it. I haven't heard that one either, so. All right. Penetrating head wounds, right? So these are your future patients, all that good stuff. So definition of a seizure, I would start that. So transient occurrence, and signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Yeah, so like the motherboard is overloaded, right? That's exactly what we said. Except that sounds way better. All right, you can have an aura, which is brief symptoms that may precede the onset of seizures. So what does an aura look like? Depends, loaded question. The aura that I see with my patient that comes in for seizure disorder is usually with them staring off and the nurse being like, hey, your patient in hallway room 3 or bed 3 is about to seize. And I'm like, how do you know? And they're like, they're doing 1,000-yard stare and then they start seizing. And I'm like, damn, you've been doing this for a while. So, and then the last definition, epilepsy. Epilepsy is a group of disorders characterized by a recurrent seizure. So epilepsy itself, we'll talk about a little bit more when we define how seizures are characterized. Gets used and thrown out like, oh, it's an epileptic seizure. But that could mean different things to different people, so just so you guys know that. So, typically when someone says epilepsy, they're talking about grand mal or the old vernacular for that. All right, seizure disorders. Etiology of a seizure is usually primary CNS dysfunction, underlying systemic disease, or drug abuse. You could have drug-induced seizures as well. So what can cause a seizure? We're not going to spend too much time on this. Anything, right? A lot of things can cause seizures, and anybody can have them. That's what I want you guys to take away from this. Can drugs cause seizures?
Yes.
Can lack of sleep cause seizures? Can
Yes.
stress cause seizures? Can studying too many PowerPoint slides from iPad cause seizures? I hope it doesn't. It suck. Can a lot of these electrolyte abnormalities, hyponatremia, hypokalemia is not on there. Can all those, yes, all that stuff can cause seizure disorder. And that's why when I have a patient that comes in with new onset of seizure disorder, I have to work that up. So I'm getting, that's when you can do your rainbow, right? And you're like, well, I don't know. Well, why are you getting a CBC and a CMP? Could be an infectious pathology. Could be inflammation. Could be MS. Could be anything. You guys have a blank canvas. You can go Van Gogh on this stuff, right? And you should be able to order broad shots across the bow and try to rule all this stuff out. Now, if I have seizure disorder and I've been diagnosed for 6 years and I come in and I had a seizure, do you need to work all this stuff up? Not necessarily. I probably will check some of it. I don't necessarily need to do neuroimaging and try to rehunt all this stuff. Chances are, if you've already been diagnosed, you're on medication, what do you think the reason that you're having a seizure is? The number one cause of recurrent seizures is not taking your seizure medication. Why do patients not want to take their seizure medications?
Makes them feel funny.
Makes them feel like crap. Makes them feel like crap. Makes them tired, makes them sluggish, makes them fatigued. So they say one day, I'm done with this stuff. I don't want it. I haven't had a seizure for a while, so maybe I'll just stop taking it. And what happens? I have a seizure. Okay. All right, history, physical exam. First, was it a real seizure? What else could it have been? Maybe it was a syncopal episode. Risk factors, right? Head trauma, stroke, tumor, arteriovenous malformation, sleep deprivation, drugs or alcohol. Signs of infections, right? So what we talked before, signs of infections, well, like meningeal signs, right? So Kearney's, Brzezinski's, neck pain, stiff neck, good, absolutely. Labs you guys can see there, it's not all encompassing. Glucose, calcium, FTA, DS, what is that? Does anybody remember that one from Clin Lab? So that's your fluorescent treponemal antibody absorption test, which is for what? Syphilis. Yeah, neurosyphilis. It's late. It's making a comeback, man. Unfortunately, it's making a comeback. Electrolytes, CBC, ESR, BUN, creatinine, LFTs. So again, a lot, right? A lot of things you guys can order to try to rule this in or out. Confirmatory testing. If I get you on an EEG having seizure activity, eureka, we've made the diagnosis. When I say we, who are we sending these folks to?
Neuro.
Neuro, or they're being admitted and neuro or medicine is doing it. As family medicine providers, we're not going to be ordering EEGs typically. Okay, I just want to make sure we're clear about that. But if you go inpatient, you get admitted because we're going to have an MRI tomorrow morning and they do an EEG and you don't have a seizure, does that mean you don't have seizures? No, it just means we didn't catch it. So you had no seizure activity for 12 hours while you were in the medicine ward. That really doesn't tell us a whole lot other than we still don't know what's going on. So These folks may have to stay in the hospital. I've got he's my nephew, sorry. And he has refractory seizures, and he has a sleepover for the next 4 days. Like, they're gonna keep him in for 4 days to take a look at his EEG. So. All right, why did I tell you that? I don't know, it just came up to me, so sometimes the filter is broken. Bless you. All right, imaging. So initial seizure is a must. So first time seizure, we got to image them. Why? What am I looking for?
Organic etiology.
What?
Tumors.
Organic.
How about tumors and
etiology.
bleeding? Let's just go with that. I didn't hear what you said. Brain? Oh, okay. That's what you said? All right. So we got to rule out that stuff first, right? So yes, patient comes in. We already talked about the labs, CT, non-con, app, very appropriate, okay? MRI is going to be superior, but again, if I'm worried about a bleed, I can't just say I'm going to bypass that CT scan with no con. It's going to take 5 to 10 seconds and send them to the MRI machine where they're going to have a massive bleed and hemorrhagic stroke, right? So we're going to get the CT non-con first. Right, in the ER, non-con might be all that's necessary. Rule out infection, mass, or bleeding, right? Patients with typical recurrent seizures, they don't always require emergent or urgent imaging. So you have a disorder, seizure pathology, it's already been diagnosed, and you're having a breakthrough seizure or you're off your medications. I don't necessarily have to image you every time you come in. It's tough. It's something you guys got to figure out when you want to and when you don't want to. Like I said, my guy in Jordan had seizure disorder, but he also had a massive hit on his head. So I'm like, I don't know if you're now bleeding inside your head, which is a whole other subset of problems. Does he get a CT?
Yeah.
Yeah, 100%. Oh, it was very bizarre because we started a line eventually. We gave him some Ativan. They called EMS from their country, and the dude had like a massive hematoma with a laceration. And I was like, yeah, he needs to go for a CT scan. And they were like, what? They like took out the IV and were like, get back to work. And I'm like, oh, I don't think that's a good idea, but I would rule against it. Yes, sir. So initial study of choice would be a CT non-con. That's going to give us a lot of baseline information to move forward. However, if it's normal, I would say that you would want to admit them. So a lot of your microinfarcts are going to show up better, and some of your soft tissue pathology, to include MS and or some of your smaller tumors, will be MRI is more sensitive specific. So I can't imagine a scenario where you would bypass doing a CT non-con first. That would be your initial study of choice. But you're going to get more information from your MRI. Yeah, I feel like I made it more confusing. I won't ask you a question like that unless I think it's fair to say like what would be the initial study of choice. But if I'm going to ask you like which would be more sensitive or specific, I won't even put non-con CT. I just think that's, if I'm drilling that into your head and then I pull an old curveball on you, that's kind of BS. I think. All right, we'll see. We'll make that a question. All right. All right, types of seizures. So generalization, right? So you have focal and general. Focal seizures, I do want us to pay attention to this. This is important. So focal seizures originate within networks limited to one brain region, right? And these were previously called partial seizures. Don't care that we know they're partial, but if it helps you memorize it, that's fine. So focal seizure is one area, where a generalized seizure arises within the rapid engaged networks across both cerebral hemispheres. So generalized, you're pretty much going to see your tonic-clonic. Focal, you're going to see one area. All right, further classification for focal seizures, you can have focal seizure. That patient can have either intact or impaired awareness, or they can be motor or non-motor. So this gets a little strange, but really, when you start breaking it down, you can have focal seizures with intact awareness that have motor and that have non-motor manifestations, and then you can have focal seizures with impaired awareness and then we'll talk about the other two. Is that confusing to everybody? Have I confused everybody enough? All right. Focal and generalized, you got to get that down. And then further classifying the awareness of the patient and then the nature of the onset with either it's motor or non-motor. I know I said the exact same thing. Sometimes you just say it more than once. Maybe it just makes it not make any sense. It's like when I'm speaking to my Spanish patients and I'm like, how are you? And they're like, no, blah, blah. And I'm like, how are you? Like, I don't know what you're saying still. All right, so further diving down, right? So you have focal seizures with intact awareness with motor function. So the patient knows what's going on and there's motor function. So literally, they get motor manifestation, they get tonic muscle stiffening, and then myoclonic muscle contractions, okay? Two named versions, Jacksonian march and Todd's paralysis. Jacksonian march is pretty neat. It's exactly what it says. It's like a seizure that starts kind of down, let's just pick your hand, and it starts moving upwards. So you can like see it marching up your arm, right? And the person is absolutely aware of it and it has a motor component. Does that make sense? Okay, Jacksonian march. The other one, Todd's paralysis, is localized paresis for minutes to hours in the involved region following the seizure, right? Not really too concerned about old Todd's paralysis, but just Jacksonian march is pretty path-defined for that. So seizure activity over a progressively large region of the motor cortex. So the patient comes in and they're like, hey, my hand, I'm losing control. It's kind of like tensing up and relaxing, and then it was my forearm, and now it's my elbow and my upper, you know, like, oh, it sounds kind of like it's moving on up, right? Maybe they have a name for it. Throw it into the old AI machine, it's going to be like, that's a Jacksonian march. There you go. So your focal seizures with intact awareness that are non-motor, you can have somatic, autonomic, and emotional seizures, which we're not going to talk too much about those, but I want you guys to be aware of that classification. Somatic meaning, I asked you guys this in class.
There's no organic etiology.
No organic etiology, but it's real to the patient, right? So, good. Focal seizures with impaired awareness, right? So you can get transient impairment, unable to maintain contact with the environment. They can't respond appropriately, and then they get this ictal phase, right? They also can have auras or automatism. So what is an ictal phase? Anybody hear that before? Like what is a post-ictal phase?
After.
Like confusion after a seizure, right? So like after somebody seizes for like 30 to 40 seconds, first of all, they're going to be exhausted.
Yes.
Yeah, they're smoked, right? And then they wake up and they're like, oh, like I just had a seizure, right? No, they're like, what the hell just happened? Usually, if they've had them long enough, they may know what happened. They may be like, I had another seizure, right? But typically, if it's the first or second time, they may not remember much of what's going on. So these automatisms, right? This is involuntary automatic behavior, chewing, lip smacking, or swallowing. So it's kind of a neat thing, right? So this evolution of focal seizures to generalized, right? So they can spread. They may start in one area and then they kind of cross both cerebral hemisphere or into both cerebral hemispheres, causing generalized seizures. Okay, and these are going to be usually your tonic-clonic seizures. Okay, generalized seizures can be broken down into absence seizures, tonic-clonic seizures, atonic, and myoclonic. God bless you. And sometimes you'll hear folks classify these all into epileptic seizures, which isn't exactly accurate, but that's okay. For our purposes, your generalized seizures, those four are going to be the ones we talk about. Okay, an absence seizure used to be called a petit mal. Don't care if you memorize that, but absence seizures, typically sudden brief loss of consciousness, lasts for seconds, and there's no post-ictal confusion. No loss of postural control. You see these in kiddos, usually childhood or early adolescence, and they can have hundreds of these a day. Usually, your teachers will say like, hey, little Chris isn't paying attention in class, he's a troublemaker, he daydreams, he stares off into oblivion, and then you can see a declination in school performance. Why?
Not paying attention.
This is poor kids having like hundreds of seizures a day, right? And sometimes all it is like you're looking and then they just stare up, blink their eyes, and come back, right? And you're like, what was that? This isn't that violent tonic-clonic seizure. It's very small. I don't care. So when we go through these, per your textbook, you can see the electrophysiological hallmark, right? I don't care that you remember this is a 3 hertz spike, slow wave. So this is small. This is small activity in the brain. Again, so this is, you're seeing kids, usually with kiddos, staring off, poor performance. I'd like you guys to consider exon seizures, okay? Generalized tonic-clonic seizures. This is your main seizure type in 10% of all persons with epilepsy. Most common seizure type resulting from metabolic derangement. God bless you. That's all I want to say there. Your tonic-clonic seizures have different phases, so I would like you guys to know this. So your tonic phase, extension of the body, usually lasts 10 to 20 seconds. Could have apnea, so there could be no breathing, and also there could be tongue biting, which is another concern. Don't care, I say I don't care, but the EEG findings, I'm not going to punk you guys out on those. Those are more for if you're going to specialize and go into neuro. So that's your tonic phase. Your clonic phase is alternating muscle contractions and relaxations. Usually lasts no more than a minute. I say usually, it can last longer, which then becomes a whole other subset of issues. And then you have your postictal phase, which is unresponsiveness and muscular flaccidity, excessive salivation, loss of bladder or bowel continence, okay? And then you can have that postictal confusion for minutes to hours. So that's another one we can kind of talk about, but again, one of the things you'll commonly see with your seizure patients is they'll either wet themselves or defecate themselves, okay? All right, atonic seizures, again, these are part of your generalized. Sudden loss of postural tone, last 1 to 2 seconds, consciousness is briefly impaired. 0, postictal confusion, okay, so that's a little bit different. Myoclonic seizures, okay, these can be classified and thought of in the same thought process of epilepsy or an epileptic seizure. So, sudden jerking in the muscles may involve one part of the entire body, right? There is a normal, common form, a physiological form of sudden jerking. If anybody go to fall asleep and they jerk really fast, okay, that's one of these. Don't think you're gonna die. Like it's okay. It happens. That's a physiological myoclonic jerk is what it is. But I've never seen anybody have one of these worse than my own 19-year-old kid. It's kind of, we're on a flight one time and he was dozing off, head banging, and then all of a sudden he it's like one of those Christmas things, we pull a string and they just go like that, and the people around him are like, is he okay? And I'm like, yeah, he's fine, he's fine. He's got bigger problems than that. He's got me as his dad. But anyways, all right, okay, this is not to memorize, but again, some things to consider by age distribution that can cause seizures. We already said that it can be caused by a wide plethora of things, but you can see there, thinking about your neonates less than a month, your perinatal hypoxia, ischemia, intracranial hemorrhage, trauma. I'm not going to read all these. There's some commonalities, right? Like clearly drug withdrawal. Like I'm not going to see a neonate like snorting cocaine, hopefully, but withdrawals from mom. Then you get into your adolescents, young adults, and even your older folks. You can see some of your alcohol withdrawals, drugs, trauma, like old people and young people fall. So something to consider. But all right, what is this? Neat little chart. Again, this is showing you that really anybody can have a seizure. So you're looking at your y-axis, your membrane potential, your x, excitatory postsynaptic potential, your EPSP. Not something I really want you guys to remember. But what I do want you to consider is somebody that has the diagnosis of epilepsy, that red line right there, okay? That red line, their threshold is a little bit lower to have a seizure or a recurrent seizure, okay? So you can see that dotted line. Don't memorize negative 50 millivolts. I think that's ridiculous. If I were to ask you that, you could kick me in the shin, just walk out, each of you. But really what's that saying is like, at this normal threshold, anybody can have a seizure, right? So we're saying all of us sit right here. For whatever reason, if something were to happen and push us into that, we could seize, right? Somebody that has epilepsy has a normal threshold that's a little bit lower, so they may be more prone to those recurrent seizures, okay? That's all I want to take away from that at this point. Complications of epilepsy should kind of make sense, but no heavy machinery or operation at high heights. No swimming alone. Why? Drown, right? So we had said that we're going to send these folks out for EEGs to Neuro. Do you think you're going to be managing folks potentially with epilepsy? Active duty, short term, maybe as they're going through their med board. Unfortunately for them, it's not going to be conducive in accordance with 40-501. Where's my reserve and guard folks? And depending on where you guys go, you may see this more frequently. So the education part is absolutely your wheelhouse. So telling them that they can't drive, that's a pretty significant emotional event for somebody that had their independence yesterday and now has epilepsy and they can't drive. But it may be regulated by the state, and if you don't tell them, and you're their medical provider, who do you think they can come after? Depending on which states you are. Texas, they can't come after. Anyways, so we're responsible for warning our patients and trying to help them out, right? So education is a huge part of what we do. So treatment, treat the underlying cause. So all those labs, right? All those labs, if we found a metabolic derangement, treat it. That should just go without saying. If we found a brain bleed, treat it. Get them to the right person. Manage their blood pressure, head at 30 degrees, anti-seizure meds, anti-nausea meds, we'll talk about it, and get them to a neurosurgeon. Avoid precipitating factors, like no kidding. So try to avoid sleep deprivation, bright lights, alcohol intake, stress, and then reflex epilepsy, which is recurrent epileptic episodes. So bright lights is an interesting one. If you potentially send somebody to the medicine floor, to hospitalist, they may put an EEG and they may stress them out. They may not want them to sleep, and they may put like strobe lights in them to try to entice a seizure. I don't know if anybody's seen that, but if you guys do internal medicine and get a neuro rotation, you may get a chance to see that. Did you guys go over anti-epileptic meds? Anti-epileptic meds? Anybody remember that?
Lost.
Just pick your favorite. Just have a favorite. I'm a big fan of Keppra. Low side effects. I'd like you to know that they have some serious side effects. So they can be hepatotoxic and hematologic toxicity. So they can blunt our stem cell production. So some of those things we need to monitor. So CBCs, LFTs, 2 weeks, 1 month, 3 months, 6 months, and every 6 months therefore after. Okay, drug interactions extremely common. Watch for that new rash onset or that desquamation of skin. Did you guys talk about Steven-Johnson syndrome?
Yeah.
What does that look like? It looks like you're shedding your skin.
Yeah.
Like that's suboptimal if that's happening to your patients.
Motor cold skin.
All right, I would like you to know ethosuximide is a Orontin for absence seizures. Just circle that for now. If I don't remember to bring it up in the review, I think there was a questionnaire or something on there. So, phenytoin. So again, these are all first line. So lamictal, tegretol, trileptal, Dilantin. So you'll see this not just an iPad, but you will get this question: PANS, PANRE, that awful cosmetic gingival hyperplasia. Did you guys talk about that one? Yeah. So wherever you go, if you have gingival hyperplasia as a question and you see phenytoin, I would highly recommend choosing it. But like I said, my favorite is Keppra because there's no drug-to-drug interactions and it's great for your old folks. So I like Keppra a lot. For your tonic-clonic seizures, right? So general first-line treatment. So lamictal, valproic acid, and then Keppra again at the bottom. All right, when to discontinue therapy. So seizure-free, 1 to 5 years. Typically it's 2. I would be leery about telling somebody come off their anti-seizure meds, especially if neurology put them on them. But if you can't find somebody to take them off it, you may need to manage it. So, but the criteria you guys can see there: seizure-free, typically 2 years, a single seizure type, it's not evolving, normal neuro exam, and no family history of epilepsy with a normal EEG, right? Status epilepticus, prolonged seizure activity lasting 5 minutes or more, continuous seizing, right? Or it's recurrent seizures with unresponsiveness during the ictal period. So again, 5 minutes of that tonic-clonic activity, we start to worry about stuff, right? We start to worry about the lactic acid they're producing, the metabolic drive, the stress on the heart. So we don't want that to go 5 minutes. So again, We'll talk status epi. If I give you guys a question there, which I probably will, we want to jump in and try to intervene. So this is a medical emergency, so you can get cardiorespiratory dysfunction, which could be what? What is like a concerning emergent cardiac dysfunction? Arrhythmia? Like an MI, a heart attack, right? So if I'm going that hard in the pain with a seizure, I could go and have an MI. So something to consider. Hypothermia, metabolic derangements can also develop. So mortality rate for status epi untreated, 20%. It's not good. Like we can jump in and fix this. So common causes of status epi, anticonvulsant withdrawal and noncompliance, number 1. I would just circle that one by far. Metabolic disturbances, drugs and alcohol, infections, tumors, and then trauma. First line, benzodiazepines. So lorazepam, midazolam, diazepam. I don't care which one you use. I really don't. But benzodiazepines are going to be your first line. Followed by probably a loading dose of either phenytoin, fosphenytoin. It's not up there, or you could do Keppra, but something to prevent refractory seizures. Okay? We got spoke to you guys. So. You want to run it back? You want to do another one? It's like really good time.